Hello, my name is Dr. Michelle Talukder, and I'm a third-year pediatric resident at Children's Hospital of Michigan. The name of my QI project is Stop the Blame Game, a systematic approach to adverse event analysis. This project was done in conjunction with Dr. Rajan Arora, Dr. Jackie Leja, Dr. Mary Najjar, and Dr. Ahmed Faruqi as our statistician. Adverse event analysis reporting is a necessary tool in the pediatric hospital system utilized to report errors and near misses. Pediatric residents are often present to witness adverse events or are involved in them. Residents may not report for various reasons, including but not limited to the following: not knowing where to report them, not knowing if it is an adverse event, unsure of the effect of reporting, and not having the time to report the adverse event or not feeling comfortable to do so. Our objective and aim were to create an educational and safe environment to facilitate discussions regarding specific adverse event analysis. The aim of this project is to make residents understand how to report an adverse event, when to report an adverse event, and increase comfort regarding adverse event analysis. 32 second and third year residents at Children's Hospital of Michigan participated in adverse event analysis case presentations from September of 2023 to April of 2024. Third-year residents were divided into groups of 3 to 4 and required to present a case in which an adverse event occurred. Each presentation consisted of 40-minute case presentations, followed by an attending-led discussion of the adverse event with a group of PGY 1, 2, and 3 residents. 2 one-hour lectures were provided to the residents on how to conduct an adverse event analysis by the director of the QI of the Pediatric Emergency Department. A pre-survey was provided prior to starting these cases, a post-survey midway through these case presentations. The survey consists of 12 questions utilizing the Likert scale to assess confidence and comfort. Wilcoxon's signed rank test was used to compare the results of the pre-test and post-test of the residents. As you can see in our results, in Table 1 in the pre- and post-test comparison, the pre-survey median was 22, while the post-survey median was 25, showing a signed rank S of 237.5 and a p-value less than 0.001, making this significant. When breaking down a few of these questions, you can see, as one of the questions states, that how confident do you feel to be able to identify an adverse event in your clinical work? When you look at the pre-survey, 12% felt very confident, while in the post-survey, 27.9% of residents felt very confident. Another question: how confident do you feel to be able to propose a possible intervention to address an adverse event, error, or systems failure? As you can see in the pre-survey, marginal amount of residents were extremely confident or very confident, while in the post-survey, 18.6% were very confident. In our last question, how confident do you feel to identify factors that contribute to medical errors or adverse events? 8% were very confident in the pre-survey, while 23.3% were confident in the post-survey. No differences were found in residents' confidence in being able to identify adverse events, the likelihood of using our system for reporting errors, or finding value in spending time going through different adverse events in our hospital system. However, residents do worry about receiving poor treatment from colleagues or hospital staff when speaking about an adverse event or error. They also feel confident about identifying factors contributing to errors or adverse events, in their ability to use a fishbone diagram to identify a problem, and lastly, there was increased confidence in the ability to propose an intervention to address an adverse event, error, or systems failure. In conclusion, reporting adverse event analyses are essential in the hospital setting. Resident education is necessary to appropriately report adverse events, and their comfortability to do so is imperative. Some limitations include our choice to exclude PGY1 residents as they were not familiar with the reporting system at this institution at the time of the pre-survey. Potential for a difference in response on the pre-survey due to previous experience residents have had with reporting adverse event analysis in this institution prior to implementing this quality improvement project is also a limitation. Lastly, for the discussion part, only a hospitalist attending and pediatric emergency attending were present. These attendings were not directly involved in the case, therefore case presentations were solely based on the resident group's experience and interpretation. Thank you.